definitely wanted to introduce Zachary Crees, who's going to present some information about COVID-19 infection or concerns for COVID-19 as it relates to amyloidosis.
All right, thank you, Dr. Linehan. And the age-old question, just confirming everyone can see my screen and hear my voice.
Yep, you're good.
Excellent. Well, good afternoon, everyone, and thank you to the organizing committee for inviting me to present to you all today. Today, rather than presenting a patient case, my presentation will instead be more focused broadly on navigating what has come to be a timely question of, is there any concern with COVID-19 in the treatment for AL amyloidosis? I have no relevant financial disclosures, and my objectives are threefold. First, I will describe some of the relevant concerns related to COVID-19 in the treatment of AL amyloidosis patients. Secondly, I'll summarize some general guidelines that have emerged for AL amyloidosis management amidst the ongoing COVID-19 pandemic. And third, I'll discuss the current guidance regarding COVID-19 vaccination in patients with AL amyloidosis. As you've already heard today from prior presentations, AL amyloidosis is a disease of monoclonal plasma cells which secrete amyloid light chain proteins that aggregate into fibrils and then accumulate in tissues, ultimately leading to organ damage and clinical disease. And AL amyloidosis is fortunately relatively rare, with about 4,000 cases per year in the United States, and the mortality rate is somewhat variable depending on the number of factors that we really don't have time to dive into more extensively here. In contrast, COVID-19 is a systemic disease caused by infection with the SARS-CoV-2 virus, with some of the earliest reports of COVID-19 coming out of Wuhan, China in December of 2019. Since that time, COVID-19 has swept the globe, leading to over 110 million cases and more than 2.4 million deaths worldwide, with more than 28 million cases and over 500,000 deaths in the United States alone. And what I'd like to focus on in the next few slides is some areas of overlap between these two diseases, which give us some cause for concern as we all adjust to the realities of managing AL amyloidosis in the midst of the COVID-19 pandemic. The first area of concern is age. We know that AL amyloidosis incidence increases with age, with a median age of diagnosis at 64 years. Meanwhile, less than 5% of patients are diagnosed with AL amyloidosis at an age under 40 years. And when we compare that to the COVID-19 high-risk groups, we see a significant overlap. And here I'm showing you data from the CDC detailing the risk of COVID infection, hospitalization, and death by age within the US population. And I've highlighted in red some of the age ranges between 50 to 64 and 65 to 74, which, as I mentioned, is the age range of the majority of patients with AL amyloidosis. And we can see that they have a twofold increased risk for COVID infection, but more concerning, they have a 25 to 35-fold increased risk of hospitalization and a 400 to 1,100-fold increased risk of death due to COVID-19. The next area of concern is patient sex. As has been mentioned previously, we know that historically males account for 65 to 70% of AL amyloidosis cases, whereas male sex has actually emerged as an independent risk factor for the development of severe COVID-19 and mortality. And here I'm just showing one of recent studies that have been published in Nature Communications. And this was a global meta-analysis that included data from 90 different studies spanning 46 different countries and 44 US states, with a grand total of over 3 million patient cases. And what they showed was that while male patients compared to female patients have an equal risk of acquiring COVID-19, men were far more likely to develop severe COVID-19, requiring admission to an intensive care unit with an odds ratio of 2.84. And men were also significantly more likely to experience death from COVID-19 with an odds ratio of 1.39. And the authors of this study at least theorized that the differences in immune response to infection between males and females lead to more effective innate antiviral responses and increased adaptive immunity towards viral antigens in females, which then generates more effective viral control and lower risk of severe disease and death. The next area of concern is that of medical comorbidities. On the left, I have a diagram that I borrowed from a very nice review on AL amyloidosis from 2018, published by Dr. Sancharawala and colleagues. And it very nicely illustrates the major organ systems frequently involved in AL amyloidosis. And on the right side, I have a similar diagram of just some of the major organ systems which are adversely impacted by COVID-19 infection. In prior presentations, we've really already reviewed many of these issues, so I won't review them again in detail here, but I do just want to highlight that COVID-19 infection in a patient with AL amyloidosis is really a case of adding insult to injury, with significant overlap in cardiovascular, renal, neurologic, hepatic, and gastrointestinal involvement, leading to significantly increased risk of acute on chronic multi-system organ failure. The next area of concern is that of immunosuppression. As we've discussed, AL amyloidosis is a disease of dysfunctional plasma cells with impaired function of the humoral immune system. So patients with AL amyloidosis at baseline are at increased risk of infection. To add to the concern of immunosuppression, virtually all the medications that we use to treat AL amyloidosis as hematology and oncology doctors are inherently immunosuppressive, targeting the abnormal plasma cells in order to reduce production of the AL amyloid proteins. And I've listed here some of the major therapeutic classes that we use frequently, including proteasome inhibitors, immunomodulatory agents, anti-CD38 monoclonal antibodies, corticosteroids, alkylating agents like cyclophosphamide, and high-dose alkylators like melphalan in combination with autologous stem cell transplant. And just to illustrate the potential impact of these therapies on patients who get infected by COVID-19, there was a recent publication in the New England Journal of Medicine that reported on markedly prolonged shedding of live SARS-CoV-2 viral particles for more than 60 days in patients that were immediately post-transplant. And this compares to the average period of about 10 to 14 days in the general population. So a markedly increased risk of not just getting COVID and having a severely worse outcome, but of shedding virus for an extended period of time. So now that we've discussed just some of the areas of concern which significantly raise the risk of COVID-19 infection in AL amyloidosis patients, I want to transition to how we then proceed forward in managing these patients who are at high risk amidst the COVID-19 pandemic. And I think I would be remiss if I didn't start with the obvious, and that is that we must be encouraging all patients, including ourselves, to engage in consistent mask wearing, maintaining social distance, avoiding large gatherings, and regularly washing our hands in an effort to reduce the risk of acquiring and spreading COVID-19. However, when our AL amyloidosis patients present with an acute COVID-19 infection, it is recommended that we hold immunosuppressive therapy, waiting to resume treatment until the patient is recovered. And for patients presenting with a new diagnosis of AL amyloidosis, like many of the cases presented here today, and particularly those with symptomatic disease or cardiac involvement, there's good evidence to suggest that their risk of amyloidosis-related death exceeds that of acquiring COVID-19, and therefore induction therapy should not be delayed. In patients who have already been started on treatment and have achieved a very good partial remission, or those with early relapses, adjusting treatment may be reasonable, but I've included an asterisk here as a reminder that there's very limited evidence, if any, to guide these sorts of quote unquote COVID risk reducing treatment adjustments. Therefore, whenever making the decision to modify a treatment regimen, we really should be endeavoring to make changes where we have reasonable evidence to suggest that that change is not going to negatively impact the effectiveness of AL amyloid therapy. And to that point, there's no current data available to support dose reductions of any of the oral medications for the sole purpose of mitigating COVID risk. So dose reductions for this reason would not be recommended. But that said, there are some reasonable changes to the treatment regimen, and they can include things like changing bortezomib from IV to sub-Q. This has the benefit of reducing toxicity while minimizing treatment times. One may also consider changing bortezomib from sub-Q to ixazomib, an oral proteasome inhibitor, and for those patients in particular with relapse disease, and that may represent an evidence-based approach to minimize in-person treatments. Changing cyclophosphamide from IV to PO is reasonable, and we have good established data that these two routes of treatment have similar pharmacokinetic profiles and efficacy. And daratumumab, when administered at lower volumes, allows for a shorter infusion time. But this is contingent on the fact that patients have already received daratumumab infusions and tolerated those prior infusions without any infusion-related reactions. Stopping or reducing the dose of corticosteroids when given in conjunction with lenalidomide as maintenance therapy is reasonable. Also, in patients who are selected, who have achieved a very good remission, for example, a complete remission, and who also have preserved organ function, early completion of therapy or perhaps reducing the schedule of in-person treatments may be considered. And I think this approach may be particularly salient if you're living in an area or practicing in an area or a region that has significantly high rates of COVID-19 infection. In patients for whom an auto transplant was planned, delaying the transplant may also be reasonable. And this is certainly something that we did here at Washington University early in 2020 when the pandemic first struck. Fortunately, we've been able to resume performing auto transplants, but a delay in transplant remains a reasonable approach if alternative treatment options are available. given the significantly immunocompromised state the conditioning regimen induces and the frequency of inpatient as well as outpatient visits needed to safely care for these patients. And lastly, I think we have all adopted the use of telemedicine visits when possible, kind of as evidenced by the fact that we're doing this symposium virtually. Unfortunately, these efforts have been bolstered by the ability to have patients take their own vital signs, use local labs, and to reduce travel, and in some cases postpone specialized therapies. So lastly, I just want to discuss the issue of vaccination for AL amyloidosis patients, which I'm sure is something that comes up frequently for all of us. And the most common question that we often get is, should AL amyloidosis patients get vaccinated? And the short answer is yes. All AL amyloid patients should get the COVID-19 vaccine unless it's contraindicated. And for reference, I've listed the CDC grouping of Group 1C that the majority of AL amyloid patients will fall into, which is that they have an age of 16 to 74 years and are at high risk of hospitalization, illness, or death due to COVID-19. So as you're hearing updates from your respective institutions and local vaccine availability, you can guide your patients appropriately. We also get asked which vaccine is the best, and the short answer that I give is that the best vaccine is whichever you can get. We currently have 2 mRNA and 1 adenoviral vector vaccines approved in the United States with FDA emergency use authorization, and all 3 are likely to be safe in AL amyloidosis patients. However, the efficacy of COVID-19 vaccination in AL amyloidosis patients, in particular those on treatment, is really unknown. These patients were not included in the clinical trials that led to the FDA approvals, and so we don't have data to gauge how effective the vaccines are. So as part of our effort to support our patients here at Washington University, we're planning a registry trial to track both the safety and efficacy of COVID-19 vaccination in specific patients on active treatments, similar to those treatments that we use in AL amyloidosis. As providers, we're often also asked to guide the best timing for vaccination, particularly for patients who are on active treatments. And again, the short answer is that patients should get their vaccine as soon as they're able to. And the timing of vaccination should not be a factor that delays induction therapy for patients with newly diagnosed and particularly symptomatic AL amyloidosis. And for those who have had a prior COVID-19 infection, that's not exclusionary. We would still recommend that those patients who have recovered from COVID-19 get vaccinated, given that immunity can wane over time. Now, when considering the timing of vaccination, if possible, a goal should be to have an ANC greater than 500 in order to optimize the chances of vaccine response, and a platelet goal greater than 50,000 in order to reduce the risk of intramuscular hematoma from the injection. And for those patients who are in a very good partial remission or better, and whom a brief treatment hold is not a concern, we would ideally hold treatment for 7 days prior to the first dose of vaccine and continue to hold until 7 days after the second dose of vaccine, which amounts to about a 5 to 6 week hold of treatment. And if such a delay is not feasible, one could consider a 2 to 7 day hold prior to the first dose of vaccine, and then restarting treatment 10 days after the first dose with the administration of the second dose at the appropriate interval without holding treatment. And this would allow for a relatively brief hold of about 2 weeks. And I'll just add that getting the recently approved adenoviral vector-based vaccine, which is a single dose injection, that with that approach, you would be very similar to a 2 week hold for treatment. That would likely be sufficient. We also get asked what's the best timing when people are on steroids. And again, we recommend holding steroids for 7 days before the first dose through 7 days after the second dose. For patients who are on maintenance therapy, and particularly lenalidomide monotherapy, there's good evidence in myeloma patients that lenalidomide may augment or at least does not have a negative effect on vaccine response. So there shouldn't be a need to hold lenalidomide monotherapy. But for patients on other maintenance therapies, we would still recommend holding for 7 days before the first dose through 7 days after the second dose if possible. For patients undergoing auto transplant, we do recommend waiting 3 months post-transplant to vaccinate. That's based on reasonable evidence looking at other types of vaccine responses in the post-transplant period. Appears that there's no decrease in vaccine response by the 3 month time point. If patients are getting vaccinated before transplant, we would likely try to vaccinate them before they get stem cell collections. And if they're going to be vaccinated pre-transplant, we unfortunately don't have data on what to do after the transplant, whether it's indicated to revaccinate them or not. So in summary, the COVID-19 pandemic has highlighted several areas of concern in the management of AL amyloidosis. Chief among them is that the patients with AL amyloidosis have high risk of severe COVID-19 infection and mortality. However, despite this increased risk, the data still seems to suggest that in most cases, the risk of morbidity and mortality from untreated AL amyloidosis exceeds that of COVID-19. And therefore, the current guidelines support the continued treatment of AL amyloidosis patients with the best available standard of care therapies amidst the COVID-19 pandemic. And lastly, vaccination is recommended for all AL amyloidosis patients unless it's otherwise contraindicated. And so with that, I'd just like to thank you all for your time and your attention, and again, for inviting me to present here. And yeah, I think we're saving questions for the end.
All right, thank you very much, Zach, for that very timely presentation.